Can you tell us a little bit about how you got interested in this line of work?
Yeah, thank you so much for the invitation. I'm really excited to be here. Um, I got interested in this field in part because of things that I noticed in the clinic as an orofacial pain practitioner. When I was doing my residency and my master's, some of the questions that made me interested were why certain patients get better and certain patients don't, or it takes more work or it takes longer for them to get better. And I noticed that a lot of times the things that would get in the way of them engaging with treatment or being able to address the contributors to their pain were things that were in their social context. So things that were happening in their lives outside of the clinic and that were either creating sources of stress or that were barriers for them to do the things that we were working with them on changing so that they could get better. And then this was, during my training as a clinician. And later on, when I started my PhD in epidemiology, I was exposed to this whole other universe of literature on the social determinants of health. And I started to gain some of the language and understanding of the terms that had been quite well developed outside of dentistry. So thinking about how the social environment shapes health in a broader way. And so I really wanted to kind of bridge those two fields to bring both the theories and also the methods so that we could understand how the social context affects orofacial pain and chronic pain more broadly.
So when you say the social context, and you mentioned earlier some of the barriers that you were seeing in clinic, for those of us who are not familiar with this idea of social determinants of health, what kind of barriers or social contexts were you seeing a lot in clinic?
Yeah, so I think the social determinants of health generally are things that influence someone's access to resources, and they are gonna change a little bit depending on the context. So on the context, I mean like geographic and social and political. Different places may have different social determinants of health that are more prominent than others, but they are all of the things that can shape someone's health that are generally outside of the formal medical context. So it can go all the way from like access to clean water and energy and nutritious food and transportation and education and legal systems that are just and so a lot of the things that create access to power in some ways and resources that shape the living conditions in which we are born and we grow and we play and work and age.
So that's really interesting, because usually, at least when I think of pain as something being very individual. In other words, there's something about a person that influences how they're experiencing pain. But if I'm understanding what you're saying correctly, you're saying that there's things outside of the person, things in the environment and in the social structure that actually might play a big role in how people are experiencing their pain also. Am I understanding that correctly?
Yeah, absolutely. We as people don't live in a vacuum, so I try to use that as kind of a catchphrase to remind us that all of the experiences that we have even though they may be very personal, very individual, they are shaped by our surroundings, our environment all the time, both like in the moment that something is happening, but also based on our previous personal history, things that happened to us in the past. And that can also go way back in time, from the environment that shaped our ancestors, and also like way back in evolutionary scale of time, about how pain came about as a mechanism to communicate between people, and also to make it more advantageous, as a society, so that we could signal to each other that we needed help, or that as an alarm for threats to our integrity. Pain has been very efficient from that evolutionary perspective. But thinking more in our daily lives, we definitely are shaped by the social circumstances that can make pain better or worse, depending on how much that social context is going to make pain more threatening, for example. And I want to make a quick note also on the term social determinants of health, because they've been used a lot. And I think that language is pretty dynamic. So there's kind of a movement that I've heard more recently to not use the word determinants, because it sounds a little too deterministic. So as if, if you have a certain type of social environment, then for sure you're going to have negative health outcomes, or you're going to have pain or worse pain. And so some of the people who are proposing to not use that term, they think that it may sound like there's no way to change that. But I am still fairly comfortable using that term. I like it, and I think it conveys a different aspect that I find important, which is to show that the social context and the social environment, they can truly be the one of the causes of health, good or poor health, depending on how that social environment is, which is in some ways different from a more biomedical paradigm that only looks at the more physical aspects of health. And in that context, the social aspects were generally framed as something that was just like a modulator of biology, as opposed to being a cause on its own. So I, in the school of thought that I generally kind of think most closely with, is that the social context is just as much of a cause of pain and health as the psychological and biological aspects. And we can talk more about that as we move along the conversation.
So this idea that pain is, in addition to being a psychological and a physiological thing, is also a social phenomenon, is really interesting. And I'm wondering if you think of all pain being equally social, or, for example, is chronic orofacial pain as social as, for, let's say, acute pain?
Yeah, that's a really great question. I don't think we have like a ton of data to support, to say which pains are more social than others. As you said, the idea that pain includes a social component is not new at all. We're building on to work that has been disseminated for centuries, depending on how you define it. But from the biopsychosocial model that has been around since at least like the 60s, 70s, 80s, then, that social component has been talked about. I I think some of the earlier reports were maybe related to acute pain. So if you think about, for example, I think there were some reports of people that had been injured in combat, for example, versus people who had a similar type of injury but was in like an accident not related to war, or like a bigger like social conflict, and that the pain that people experienced and also the kind of progression after the pain was very different depending on that social context. And I think, yeah, like we maybe can think of situations in our own lives where we got injured and we didn't even notice because we were doing something that was very important. So in the acute pain setting, that I think has been observed for a long time. And thinking about chronic pain, I think that is the bigger focus of my work as a clinician and pain epidemiologist, because chronic pain has a very large societal impact. And some of my dissertation work, for example, I was looking at differences in prevalence of high impact chronic pain, which was defined as pain on more than half of the days for at least 6 months, with an impact on daily activity. So it's pretty impactful pain. And that could be, from that definition, it could be in any part of the body. And I was looking at, the prevalence of high impact chronic pain, for example, by different levels of household income. And adults in the United States that have lower income have a much higher prevalence of high impact chronic pain. And then I was, as a dentist and orofacial pain practitioner, I was interested in breaking it down by pain in different locations to see if some of them had a stronger sort of effect of that social inequity by income. And what I found was that actually we had measures of pain in different locations, I think in 5 or 6 different locations, and they all had somewhat similar magnitude of that association with a household income. What explained some of that was the fact that people who had high impact chronic pain had a very high level of comorbidity between pains in different sites. So when we were looking at pains in different sites for people with high impact chronic pain, it was almost like we couldn't separate pain by location, because people who had high impact and had one pain were also much more likely to have pain in other body sites. So they had multiple chronic overlapping pain conditions, if you would, even though it wasn't measured in that particular way. So in short, to your point, we know that chronic pain has likely a big influence of the social context. And because the social context influences pain through kind of general or more central mechanisms to make people more sensitive to pain, it probably doesn't make that much of a difference if where the pain is felt in the body. Although you could make a case, again, as our bias as dentists, we know that the face is really strongly related to how we communicate with people and how our sense of identity is. So we can see how those things would make pain in the face impactful for our relationships and our social engagement. So there's also that aspect that makes this whole topic more relevant for orofacial pain specifically.
So one of the things that you found, if I'm understanding it correctly, is that people from low socioeconomic status had higher prevalence of high impact pain. But I want to ask a slightly, well, I think it's a slightly different question, which is if you had two people from two different socioeconomic statuses and they had the same pain, right? Not different pain, but the same pain. Do you think that that pain would be more impactful in someone with a lower SES because it disrupts more things? Like they might not have the resources to take the time off work to rest and get, could the pain be more impactful because of the social factors that are present?
Yeah, I think you're definitely on the right track. We're in the process of refining the research to answer those questions, but we do see that for people that report, for example, the same intensity of pain, people that are in lower social positions of defined in many different ways, but definitely where there's more research is socioeconomic position. Then we know that pain impact is also greater for those who are in those either marginalized or less resourced positions. And I think that in some ways we're still figuring out the direction of that relationship. So there's a chance that some of this difference is because those social conditions that may make people more likely to experience higher impact, and also could be the opposite direction, which is pain that is more impactful can impact someone's ability to work and maintain or achieve different levels of socioeconomic position. And so a lot of the data that we have so far has been cross-sectional, so we can't really tease those two directions apart, but it's probably a combination of both. And we do know that having resources to address acute pain and chronic pain and have the ability to engage with treatment and have time and resources to make changes in lifestyle, for example, can depend on money. And so it would be understandable that those could be barriers for having pain that is more manageable or less impactful.
So one of the implications, at least as I think of it, of your line of work, is that if we were to somehow be able to change the social environment or to change the resources, that then we could also potentially impact people's pain. Is there any evidence, or has anyone done these kind of bigger picture interventions at the, city, state, country level to show how different resources and different policies actually influence chronic pain in those regions?
Yeah, so I love that question. So one of my personal and professional missions is to help the narrative about pain and social determinants of health move towards our understanding that these things can be changed, they can be modified. And yeah, like a very compelling argument for that new narrative would be to show how when you change the social environment, how does pain change as a consequence? And that's on my dream study list. I would love to do something very specific to pain, and I think that I have a couple things that are in planning phase that can be foundations for that type of question. But one of the best examples in the literature that is analogous to that type of question is in the mental health literature. That there's a very famous study called Moving to Opportunity, and it was I'm trying to remember if it was fully randomized or if it was like semi-experimental, but it was a very strong design. And I want to say it was randomized. So people had the opportunity to use a voucher to move to a neighborhood where it was a more resourced neighborhood. And in that study, they showed positive impacts on depression symptoms that I think that was kind of a new breakthrough study, because it was the design was strong enough that people could interpret those effects as being causal, and also it was in some ways scalable, or you could think about ways of that neighborhoods could be changed, or people could be relocated. There's obvious downsides to that as well. When someone moves from one place to the other, they may lose some of their social networks that were in their previous neighborhood. So there were definitely pros and cons. I would highly recommend, if any of you out there are interested in this type of social intervention and understanding their impacts on health, to look this up. It's called Moving to Opportunity. And I think that as we know about some of the mechanisms for how the social context may affect pain, and how mental health and pain are also very closely related, we could argue that those same positive changes in the neighborhood that were helpful for depression may also be helpful for pain. We just need to prove that in our research in the coming years, and to use that research also to support broader changes that, as we know about the big cost that both to individuals and society of chronic pain. I think those could be, some additional pushes that can go towards positive social changes.